Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. 31-year-old male who presented with complaints of palpitations and syncope. 2D echocardiography revealed dilated right atrium and right ventricle. CT chest was reported as normal. Cardiac MRI was performed for further workup. So these are cine images of the heart, 4-chamber view, and it shows the right ventricle and right atrium are dilated. As you see over here, they are definitely larger than the left ventricle. As a routine protocol, when we obtained the flow images of the ascending aorta, the stroke volume was 56 ml, and the flow through main pulmonary artery was 156 ml, significantly increased. So basically the ratio of flow between MPA, that is QP, and systemic, that is aorta QS, was significantly increased. And hence we again looked back at the images, and then as you see over here, we can see some interatrial communication, as you see over here, suspicious of atrial septal defect. Post-contrast wide images, it reveals anomalous, we see this is the interatrial septal defect over here, and there was anomalous venous drainage. Right superior lobar pulmonary vein was draining into superior vena cava, which is seen over here. So the findings are suggestive of QP upon QS ratio is more than 1.5. This indicates hemodynamically significant left to right shunt. So these features are suggestive of atrial septal defect. And as you see in our case, that there was a deficiency of a common wall between SVC and right atrium. As you see over here, SVC and right atrium, this common wall is deficient, and hence diagnosis of sinus venosus type of atrial septal defect was made, and this was associated with partial anomalous pulmonary venous drainage. As we had seen, right upper lobar pulmonary vein was draining into superior vena cava. This was the transthoracic echo findings, and it confirms the presence of abnormal communication, confirms the presence of ASD, and final diagnosis of superior sinus venosus ASD with partial anomalous venous drainage of right upper lobar pulmonary vein into right atrium was made. Sinus venosus ASD closure was done, and SVC augmentation was done with pericardial patch. And this is the post-operative transesophageal echo, which confirms that closure of the ASD. And then patient is coming for the regular follow-up, and he's doing fine. So whenever you see a dilated right ventricle, you have to think for whether it is either pressure overload, as you see in cases of pulmonary hypertension, or RV hypertrophy, volume overload when the RV is significantly enlarged, or it could be either in cases of RV primary cardiomyopathy. Think of 4 causes, whether either it is because of the intracardiac shunt, as we had seen over here in our case. It could be either because of valvular regurgitation like tricuspid or pulmonary valve abnormality. It could be result of pulmonary hypertension and back pressure changes, or a primary cardiomyopathy involving right ventricle, that is arrhythmogenic right ventricular cardiomyopathy. So these are the main causes of dilated right ventricle. It is important to obtain phase contrast cardiac MR in all the patients. As we had seen in our case, the main clue was achieved with this phase contrast CMR. Flow of aorta and MPA is essential in all cardiac MR studies. Few important points that the planning has to be aligned orthogonally in perpendicular direction to the major axis of the blood vessel, and you have to check it in 2 spatial directions. Slice thickness of 5 to 8 millimeter, and in plane resolution of at least 1/10 of the vessel diameter. You have to use correct Wenck. Wenck is basically velocity encoding gradient, and especially you have to check that from the 2D echo findings, especially in cases of aortic stenosis, when the flow velocity is increased, you may have to adjust your Wenck accordingly. And it is basically lowest velocity without any aliasing has to be used. Temporal resolution of less than 50 milliseconds between phases is suggested, and you can either use free breathing or multiple signal averages. Every phase contrast images will give us a set of phase and magnitude images. Magnitude images are used to draw a region of interest, while phase images are useful for assessing the direction of the flow as well as aliasing. So for planning of the aorta, you can use the sagittal view or LVOT view. And in sagittal view, you have to take a plane above the right main pulmonary artery in this way. Ideal length for normal patients for the aorta would be around 200 centimeter per second, while pulmonary artery can be planned on the MPA view or the RVOT view, and it has to be perpendicular in both the planes. So the length for PA is slightly less, around 180 centimeter per second can be used. Something about atrial septal defect. Basically, these are the congenital shunts between the which leads to abnormal communication between both the atria. It could be either ostium secundum atrial septal defect, which are most common, and they are located in the central portion of the interatrial septum, and it has no connection with any atrioventricular valves. While primum atrial septal defect is situated caudally and it is connected to the AV valves. Sinus Venosus ASD, as we have seen in our case, it could be either superior near the connection of superior vena cava, or it could be inferior, also known as coronary sinus defect, near the connection of the inferior vena cava. So learning points from this case are that flow calculation of aorta and MPA should be performed with every cardiac MR examination. Look for extracardiac structures, all pulmonary veins, because they also provide important clue in complete assessment. Similar concepts can be found on our book, Cardiac MRI Simplified. Any feedback, suggestions, please mail us on info@mricardiac.com. Thank you.